This is Radio Health Journal. I'm Reed Pence. This week, biofilms, how bacteria fight off antibiotics.
So it's the ring in the toilet, it's the ring in the tub, it's the plaque on our teeth. They incorporate substances from around them, and they weave this tight matrix around themselves to protect themselves.
More on biofilms when Radio Health Journal returns.
Colorectal cancer is the second leading cancer killer in the United States. It can be prevented with screening, which is a big reason that colon cancer deaths are down over the past 15 years. Here are the facts. Colon cancer strikes men and women equally, and most people who develop it don't have a family history. The biggest risk factor? Your age, according to Dr. Doug Fagel, president of the American Society for Gastrointestinal Endoscopy.
Everybody should be screened for colorectal cancer starting at age 50 or earlier for people with certain risk factors. Colonoscopy is the most effective screening test and the only one that can actually prevent colon cancer. Some people worry about preparing for colonoscopy, but afterwards, people often tell us they're glad they had the test or wish they'd done it sooner. So our message is simply this: prep, scope, live.
Find out more about getting screened and why it's important at screenforcoloncancer.org. That's screen, the number 4, coloncancer.org.
Disinfectants are big business. Even though we couldn't live without the trillions of bacteria living inside our bodies, we try to get rid of them everywhere else whenever we can. But we're learning that that's a tougher job than we thought. Scientists are changing how they think about bacteria.
And it changes this from thinking about primitive single-celled organisms, that live in isolation and are just floating around at the whim of the currents, to thinking about these as multicellular structures in which microbes are communicating with each other through the metabolites that they secrete, that they're probably cooperating metabolically, that there are division of labor strategies.
That's Dr. Phil Stewart, professor of chemical and biological engineering at Montana State University. He says what's prompted scientists to upgrade their estimation of bacterial communities is something called biofilm. Montana State's Center for Biofilm Engineering is one of the world's leading biofilm research centers.
Biofilms are microorganisms. We're talking about bacteria or yeast, for example, that are banded together in dense aggregates, usually stuck to a wetted surface. So a classic example is dental plaque. Most of us confront daily with our toothbrushes. If you're out for a hike and cross a little stream and slip on a slimy rock, that was a biofilm, probably a mixture in that case of microalgae and bacteria living together in a sort of symbiotic relationship. So this turns out to be very, very common. We would say even ubiquitous, ancient survival strategy for microorganisms.
People deal with biofilm every day. When they're scrubbing, when they're using chemicals, more often than not, they're dealing with biofilm. So it's the ring in the toilet, it's the ring in the tub, it's the plaque on our teeth, the things on the counter, things in the sink. So whenever there's a nutrient source, a little bit of water, bacteria will adhere to a surface. Once they're attached, they're going to grow quite differently than what we learned about in our science classes in school.
Dr. Randall Wolcott is medical director of the Southwest Regional Wound Care Center in Lubbock, Texas, one of the few wound clinics that focuses on biofilm and infections.
They secrete a substance around themselves. They incorporate substances from around them, and they weave this tight matrix around themselves to protect themselves. So they're quite different. I mean, think of the plaque on your teeth. You don't take antibiotics to cure those. Antibiotics can help, but mainly it's brushing and putting topical things on them to suppress it. You don't get rid of them. You keep them knocked down so that they don't cause cavities and periodontal disease and stuff like that. So people really deal with biofilms every day of their life, and they know the strategies for dealing with those bacteria. They've just never known to call them biofilm.
I think Harvard did a study that about 100,000 people in the United States die per year from biofilm-related illnesses. And now these appliances that people have. For example, like a dishwasher, you'd have like the slime or the contamination build up inside a dishwasher.
Biofilm inside your house is an important issue too, according to Bill Sukup, president of Scientific Biofilm Solutions and Healthy Household Cleansers, which make products designed to attack biofilm and the substances that help them grow.
And it's not just biofilm with our cleaners. We're trying to remove other contamination too, like the dishwasher would be fats and oils, food deposits, scale, that builds up inside the dishwasher, and they don't get hot enough to kill or remove biofilm. The backside of a washing machine is full of all kinds of contamination. The biofilm, which is like the slime on the backside of, say, a drum-ended washing machine, the biofilm absorbs the contamination and then feeds off of this contamination. So you have dirt and oils and fecal contamination that are feeding the biofilm, and that's what's keeping the bacteria alive on the backside of the drum and inside the washing machine. So that's what needs to be removed.
Stewart believes biofilms in household appliances are less of a health hazard unless someone's immunity is compromised. But he says biofilm slime, the matrix holding everything together, can certainly be unpleasant and then some.
It's a watery hydrogel made of proteins, polysaccharides, even nucleic acids. So not only are there the microbial cells, but there's this matrix surrounding them that they have exported, and that matrix offers some degree of protection just immediately. It offers some mechanical protection. So it's harder to tear that structure down than it is just a lone cell.
However, lone cells are what most scientists study. Bacteria in the lab don't live like those in real life. In the lab, they float freely with nothing to stick to and with plenty of food, so they have no reason to form a matrix. But grouped together as biofilm, bacteria have plenty of advantages that haven't been studied all that well.
One of those is that the ones in the center of a biofilm can become starved for nutrients and stop growing, and that turns out to be a great way to defeat an antibiotic. So most of our antibiotics target actively dividing microorganisms, and if some fraction of the population in a biofilm, for example, simply stops growing, they can outlast an antibiotic treatment. The other big protective mechanism is that the antimicrobial chemical doesn't actually penetrate all the way in.
Stewart says big numbers provide one other defense. Most biofilms are made up of more than one kind of bacteria, so an antimicrobial attack on one or two types won't touch some of the others.
Very often in these real-world biofilm systems, we find a whole zoo of different microorganisms living together in the same biofilm. So, for example, hundreds of different species of bacteria have been isolated from human dental plaque. It's a rather fabulous mixture of organisms with very different properties that live together in close proximity.
Given all those defenses that biofilms have, it's no wonder that it can be extremely difficult to get rid of them. Washing machines and dishwashers are one thing, but a biofilm infection in the human body can be extremely serious. Yet medicine is only beginning to catch up with the discovery that biofilms and infections are closely related.
The European Infectious Disease Society says if you get those chronic infections, that it's biofilm that's causing those infections, which means every tissue of the body suffers a chronic infection. In heart valve, it's endocarditis. In bone, it's called osteomyelitis. On skin, it's called a chronic wound. So that's biofilm that drives that. There's host factors, but at the end of the day, the chronic wound is a chronic infection.
It now looks like diabetic foot ulcers, venous stasis ulcers, decubitus ulcers, or bed sores very often involve a polymicrobial, a mixed species biofilm growing in the damaged tissue of that wound and setting up this stalemate or standoff in which the biofilm is present and defended and can't easily be eradicated by topical antiseptics or the host defenses. Yet the presence of the biofilm at the same time is arresting the normal healing process. These are sores that can stay open for weeks or months or even years. They're really tragic for the patient.
But chronic wounds aren't the only place where biofilm infection is especially troublesome. Stewart says implants are also prone to infection.
These are typically slow-moving but very persistent infections, and they tend to be associated with implanted devices or tissue that is damaged somehow. For example, prosthetic joints or artificial hip has a certain risk of developing an infection that's directly associated with the implant, and it's only about 1% of people who end up with that problem, but it's actually a rather catastrophic problem if your hip gets infected. It's a huge expense and trauma to the patient to deal with a hip joint that becomes infected, or a knee joint. Same goes for catheters, hernia meshes, and there's so many biomaterials that are used in medicine these days. They all have a risk of an infection.
Still, Wolcott says biofilms are a hard sell to doctors. Most of them don't really know much about biofilm, and the normal medical world can make it a hard concept for them to grasp.
We're still steeped in the one thing causes the infection, everything else is a contaminant. So that's the thing we run in with when we try to talk about biofilm with clinicians. It's like they'll say, well, you're naming 4 or 5 different organisms. Which one's causing the infection? That's hard to get across. Used to, you'd get a Staph aureus report back from your culture. The culture reports one thing, you treat the one thing. If you get back 5, 6, 7 different microorganisms that you've never heard of before, it makes it more difficult for your treatment decisions, and so they've been very resistant to that.
But when doctors embrace the concept that treatment will have to be a little different than how they'd combat a single organism, Wolcott says they can have much more success.
We did it was 4 months. We identified 93 patients that were told that they had to have their limb amputated for ulcers. The vast majority were diabetic foot ulcers. There were 4 or 5 venous leg ulcers, but they were recommended by their treating physician to have a major limb amputation, either below or above knee, and they all healed but 3. So, we were successful in cases where the treating physicians that had them before thought that they were at the end of their road and they could never heal.
Wolcott says the key to treating biofilm infection is the realization that more than one approach is necessary. At first, the strategy was almost dental, brushing to get rid of the biofilm, then topical antiseptics to prevent it from coming back. Over time, those multiple strategies may become more and more important in medicine as we learn about the importance of inflammation and biofilm in many human diseases.
You can't overstate the problem. If you look at cancer, 25% of cancers are caused by persistent inflammatory conditions, like colon cancer and stomach cancer, and now stomach cancer is directly linked to bacteria. The H. pylori causes most stomach cancers. So bacteria, this biofilm phenotype bacteria, with its persistent inflammation, can cause a significant amount of the cancers that we see in the United States. Atherosclerosis looks like it's going to be a biofilm disease. That's heart disease and peripheral vascular disease, so that's big. But if you take that out, if you just look at the chronic sinus infections and Crohn's disease and chronic prostatitis and ventilator-acquired pneumonia and infected medical devices, it's well over 10 million, probably closer to 20 million Americans suffer from those chronic infections. That's all biofilm disease.
You can find out more about all of our guests through links on our website, radiohealthjournal.net, where you can also find archives of our programs. You can also find them on iTunes and Stitcher. I'm Reed Pence.
Medical notes this week. We reported last month about the Zika virus and its effect especially on pregnant women in Central and South America. The virus is also established in Puerto Rico, and a few cases have occurred in the continental U.S. Now, federal health officials have confirmed that the first Phase 1 clinical trials on a Zika virus vaccine will likely begin this fall, and if they're successful, that could open the way for Phase 2 trials early next year. Still, it could take years before a Zika virus vaccine is approved. Here's another example of too much of a good thing. A study in the Canadian Journal of Cardiology finds that exercising too much raises the risk of atrial fibrillation more than 5-fold. AFib, as it's called, can lead to a stroke or heart failure. However, researchers say it takes several hours of exercise almost every day to raise the risk. Not exercising at all is much more dangerous. And finally, lack of sleep has been linked to weight gain, and now scientists are beginning to understand why. It turns out that sleep deprivation literally gives you the munchies, boosting endocannabinoid signals in the brain just like smoking pot does. Research subjects who were sleep deprived for 4 days had higher levels of the chemicals than when they were well rested and simply couldn't resist eating cookies and chips. And that's Medical Notes this week. More in a moment.
Thank you for listening to Radio Health Journal, a production of MediaTrax Communications. If you enjoyed this week's show, please leave a review on iTunes or share it with a friend. You can find more Radio Health Journal stories about health, science, and technology on iTunes, Stitcher, and at radiohealthjournal.net.